Lucky Land Casino, asking people, what's the weirdest place you've gotten lucky?
Lucky? In line at the deli, I guess?
Aha, in my dentist's office. More than once, actually.
Do I have to say?
Yes, you do.
In the car before my kids' PTA meeting.
Really?
Yes.
Excuse me, what's the weirdest place you've gotten lucky?
I never win and tell.
Well, there you have it. You can get lucky anywhere, playing at LuckyLandSlots.com. Play for free right now. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18 plus. Terms and conditions apply. See website for details.
Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, Eric Christensen, and you can find me at LinkedIn.com. You can check out my profile there, Eric Christensen, PharmD, BCGP, BCPS, probably the social media platform I'm most active on. So if you got a question, suggestion, I do my best to try to respond to all of those that I can in a timely manner there. reallifepharmacology.com. Go check it out. Sign up on the subscriber list, and you'll get a free 31-page PDF on the top 200 drugs. So definitely feel free to do that. You'll also get updates as to when we have a new podcast available on a different drug or disease state as far as pharmacology goes. All right, so let's get into it today. Calcitonin is the drug of choice for the podcast today. Brand names of this medication, Miacalcin and Fortical. Now, this medication is classified as an osteoporosis agent. It is definitely down the line after bisphosphonates and other medications. I have seen it used in clinical practice to help with pain associated with compression fractures. There may be some evidence demonstrating some efficacy there. It also is indicated for hypercalcemia as well, which I haven't seen personally used very often. With this medication, mechanistically, it works by blocking or opposing the action of parathyroid hormone. Now, ultimately, what that ends up doing is it results in the blocking or inhibition of osteoclast activity. Now, if you remember osteoclasts from, I think it was Lendronate to the bisphosphonates podcast, osteoclasts break down that bone. And, their activity is what contributes to osteoporosis. So obviously it makes sense if we prevent the osteoclasts from functioning properly or functioning at full capacity, we're going to potentially help bone mineral density and manage osteoporosis. Let's talk about administration because this is a really important thing. This is not an oral medication. Okay, it's available as an injection, and it's available as a nasal spray as well, which is kind of unique. I would say in practice, the nasal spray is what I have seen way more common than the injection, because in general, who wants to get an injection if they don't have to, compared to maybe a nasal spray might be a little bit easier there. But there is some quirks with that nasal spray that I have seen quite a few mistakes on. So, one, the dosing is one spray into one nostril once daily, and you want to alternate those nostrils every day. So day one, you do in the left nostril. Day two, you do in the right nostril. Do not do 2 sprays on the same day. Okay, so that's something we might do with some of the allergic rhinitis medications, like nasal corticosteroid, for example, is to do it into both nostrils on the same day. But that is not how calcitonin or miacalcin is to be used. A couple other things with kind of some quirkiness with miacalcin. So it does expire after it's out of the fridge and opened in 35 days. So it's got a quick expiration date. In addition, it's ideal to keep that bottle in an upright storage position. So this is also something I've seen. And the reason being is it could, the bottle could lose its prime if it's inverted or sideways. And then what happens is the patient doesn't get the adequate dose when they squeeze down on the trigger, basically, and releases that dose. So some really important, I think, education points on this medication regarding storage. And then initially, when it's first open, we've also got to prime it and make sure we're actually getting that dose out of that medication there. All right, let's get into adverse effects. Probably one of the biggest things I think about is if this medication is used, potentially can be, for hypercalcemia. Obviously, the drug can lower calcium levels, which in a patient with normal or borderline low calcium levels, that could potentially be an issue. So that is something to think about and look out for there. Nasal administration. Whenever you use nasal administration, you can definitely run into, irritation and rhinitis and nosebleeds. So that's definitely something that can happen from that medication as well. There are some, warnings, precautions on certain malignancies. So I think that's probably an important education point. Clinical practice, I haven't seen any issues with it, but there have been some associations and reports with that that probably should be addressed there. If using this medication for osteoporosis, I always think about supplementations and diets, meaning looking out for vitamin D supplementation, calcium intake, things like that, to make sure patients have adequate amounts of that to ensure that their osteoporosis is well managed in general there. Rarely there have been associations with antibody formation with this medication. So this isn't incredibly common, and I don't think I've talked about it in the past, but there is potential sometimes for the body to create antibodies on certain medications. And if this happens, basically those antibodies do what they're meant to do, and they essentially neutralize the drug, change it, alter it, so it can't get into cells and have activity and things of that nature. So if you've got a patient that's clearly not responding to the medication, and if you remember, antibody formation generally takes time. When we give a vaccine, for example, we're instantly covered for that disease state. So it may take some time for those antibodies to develop and to actually see that non-response. But again, it is something to kind of think about if you're not seeing the response you want, that it could potentially happen with this medication. All right, so let's take a quick break and we will wrap up with drug interactions. If you're in the market for pharmacist board certification study material, or if you're just looking for a good read on clinical medication management, whether you're a nurse, a physician, a pharmacist, or any other profession that handles medications, administers medications, definitely go check out meded101.com/store. We've got a growing list of resources for all sorts of healthcare professionals, as well as a lot of study materials for certain board certifications for pharmacists like BCPS, NAPLEX, BCGP, ambulatory care, and BCMTMS. So go check those resources out at meded101.com/store. Support the sponsor and get some unique educational products there as well. All right, so let's finish up on drug interactions. And as a reminder, I do have that book. You can find Common Drug Interactions in Primary Care. You can find the link to that at meded101.com/store. Click on Audible Books and you'll be able to see that. you can get your first book for free on drug interactions, where I talk about a lot of the most common things and some clinical pearls associated with that. It's a 10-hour book, so there's a lot of content in there. So anyway, drug interactions with calcitonin, there really, in all honesty, aren't a lot. And the first thing I really think about with drug interactions is that effect that it can have on calcium. So remember, it can drop calcium levels. And if we're using other drugs that may also drop calcium levels, that could potentially have a little bit of an additive effect. So what drugs can lower calcium levels? So I think of loop diuretics, for example. Some of the other medications for osteoporosis, bisphosphonates, denosumab, those have the potential to lower blood calcium levels. And one other one, not incredibly used, but you might see it in chronic kidney disease, is cinacalcet. If you remember, this is a medication classified as a calcimimetic, and that medication absolutely can lower calcium levels. So keep that in mind. If you happen to see a patient on two of these medications that may lower calcium levels, you might want to do a little more due diligence and check those levels a little bit more often there. Like I said, there aren't many drug interactions. One other one I wanted to mention was lithium levels. It has the potential to potentially decrease lithium levels. So again, I don't think I've ever seen a patient, at least that I recall, that's on lithium and calcitonin, because they are kind of two rarely used medications. I don't see them a ton, but certainly, it would be something you would want to look out for if you're starting calcitonin in a patient on lithium. We'd maybe check some levels and monitor and that type of thing. So I think that's going to wrap it up for today. Be sure to head to reallifepharmacology.com, sign up, snag that free 31-page PDF. All it takes is an email. Also, if you enjoyed the podcast today, found some useful clinical pearls, definitely leave us a rating and review on iTunes or wherever you're listening. And also share us. Shoot an email to a colleague, friend, classmate. If you teach in pharmacology in college or something like that, definitely feel free to share this free resource with all your students and help everybody get better and pick up a few pearls on pharmacology. So I'm going to sign off for today. Thank you so much for listening. Again, Eric Christensen. You can find me on LinkedIn. Shoot me a message there. Also, hit the contact button on meded101.com. Those emails will go directly to me. I'm going to sign off. Thank you so much for listening, and take care and have a great rest of your day.
We're an Instacart family.
Oh my goodness, we saved so much time with same-day grocery delivery.
So we joined Instacart Plus.
And now we're saving more money.
We get unlimited free delivery on orders over $35,
5% credit back on pickup,
and a family account to shop together.
Did you know members save $460 a year when they order at least once a week?
I do now. See how much you'll save. Visit instacartplus.com for 2 weeks free. Average savings exclude membership fee. Individual savings may vary. Credit back excludes alcohol. Paid membership auto renews. Additional terms apply.